Hi, friends. Welcome to Heartforward Conversations from the Heart. This week, you might want to grab a notepad because a lot of good information will come your way. I promise you that at the end of this hour, you will feel like you've been handed some important puzzle pieces that will help you make better sense of the conundrum that is our system of financing mental health care, treatment, beds, crisis response, you name it. My guest is Alex Briscoe, who spent 13 years in the health agency in Alameda County, 7 years as director. This $700 million agency located in the Bay Area of California incorporated mental health, health, and public health services under one roof. For months, I've been searching for just the right person to interview. I needed a smart and caring person who could translate into layman's terms how our counties pay for mental health care. Spoiler alert. If you thought local taxpayer dollars fund mental health, you are misinformed. That was me up until a couple years ago. I've been on this journey of trying to understand this more completely, so I am dragging you along with me. Too often I see community members rail up against the mayor or the city council about the evidence of untreated mental illness in the homeless population. But there is not much a city can do about this issue in and of itself. And even the county runs up against limits and rules and restrictions that make it very difficult to truly meet the whole person needs of people living with mental illness in our communities. Why is this so hard? Alex says that a mentor of his, Dave Kears, formerly the health director in Alameda County, had a saying, quote, "We have the most complicated descriptions for the things we understand the least." Please listen along as I posit 10 observations I've curated about this uber-complicated funding imbroglio. I hope this stimulates some thinking as to how you might ask the right questions to policymakers and elected officials in your own community. Hi, this is Carrie Morrison, and today we are at episode 9 of this season of Heartforward Conversations from the Heart. And I'm really pleased that my guest has actually traveled down from the Bay Area so we could do this interview again in person today. I want to welcome you, Alex Briscoe. Alex is a principal with the Children's Trust, but he also has a really interesting background we're going to value highly for our conversation today. So welcome, Alex.
Thank you, Carrie.
So glad you're here.
Thank you.
So I have been looking for the right person to talk to try to unravel the imbroglio that is our public mental health financing system. And I landed on Alex because I've been trolling him on the internet and listening to his YouTube videos and podcasts, and I think he's going to be able to translate this into language that the layperson can understand. So I'm going to walk you through today like 10 observations that I've had as a layperson, Alex, and you can either say that's true, that's false, or maybe that should be adjusted. So we're going to do that in less than an hour. But before we do that, let's get to know you a little bit. Tell me a little bit about your origin story, how you wandered into this space of the public health systems, your commitment to public service. And I can also tell from your CV that you have a huge heart for children. So share a little bit of your origin story.
Well, my ancestors raised me in a culture of service, not much God, plenty of service. And one of my first jobs was working in my hometown of Philly. We were actually one of the first youth build programs in the nation. We worked with young people 18 to 24 who dropped out of high school, and we rehabbed abandoned buildings and prepared young people for pre-apprenticeship programs. And it was a really formative experience for me. I mean, I was only in my 20s myself. We did all kinds of things wrong, but one of the major takeaways for me was how beautiful and smart and intelligent poor people were. I was just overwhelmed with the kind of capacity and wisdom and thoughtfulness of the young people we were working with. And I also was turned on to this idea of revenue-producing social justice work. Not only were we a high school, we were the first charter school in the state of Pennsylvania, we were also a general contracting company and produced about a third of our budget through being a Section 8 housing provider.
By building things?
Gut rehabilitation, abandoned houses, and working with young people. They would work side by side with the homeless families they were moving in. It was actually a really beautiful, powerful experience.
And teaching skills along the way.
Absolutely.
Yeah.
Every young person got pre-apprenticeship work in the trades. But that couple million we made through earned revenue, we didn't have to ask anybody for. And that's important because it eventually led me to healthcare. But I learned the value of sort of unprogrammed dollars in social justice work and how not every dollar is created equal. I hope that's a theme we'll get into.
Mm-hmm.
And how you use them strategically and respectfully is really important. So then I became a therapist for teens. Worked for the Oakland Public Schools, eventually for a level 1 pediatric trauma center in Oakland. Very, very difficult stuff. Saw a lot of human suffering. And then I was recruited literally out of Children's Hospital Oakland by a very important man in my life, Dave Kears, who was the health director in Alameda County. And I mean, long-winded way of saying, he basically said, I think you can do my job. Come train and work with me.
Which is no small job.
It was, running $1 billion plus health authority, ambulances, hospitals, public health, mental health, a lot of kids stuff. I remember thinking at the time, the county? Like, who's that? But I realized over time that counties are where the state and federal dollar connect before they become a service.
Yeah.
To your point, if you want to understand this fragmented, tough imbroglio. If you want to understand this really difficult, fragmented system, you have to begin by unpacking it with the county. The counties are the essential actors in the health and human service safety net. So understanding who they are, how they work is really important. But Dave Kears gave me a very important piece of advice. He said, we have the most complicated descriptions for the things we understand the least.
That's our way of making sense of something, perhaps.
Well, his point was, if someone can't explain it to you, then either they don't get it or they're trying to get something from you.
Wow.
So he was like, indulge that part of you that wants to understand. Don't be that guy in the meeting who makes it all about his understanding, but on the other hand, don't let it go.
Right.
And I think what, for people listening to this podcast or folks working in systems, it can get overwhelming. And my recommendation is like, stop, pause, breathe. But we made these problems. They can be unmade by us.
And we need to lean into that. Yeah.
Embrace the detail. Understand how the money flows.
So we're going to do that. So trace then how you went from the county then to your current work.
I worked for 12 years for Alameda County, the last 7 as the leader of the health system. It was an extraordinary time during the adoption of the Mental Health Services Act, the implementation of the Affordable Care Act. It was heady. It was crazy. I was far too young to be given that level of responsibility. And I paid a price personally and professionally. I think I left sort of in a pool of depression and sadness, but also had extraordinarily powerful experiences and learned a lot.
Yeah. And now you are?
Well, I left there and went to work for some very wealthy people, giving their money away, and somewhat focused on homelessness, because we did a lot of work in the public health department, as you know, around homelessness. And some very wealthy folks in San Francisco wanted to take a crack at it. So I helped them design a $100 million initiative. And so I left there and started something called the Children's Trust, which is in some ways a broader attempt to look at the social contract we as a culture have with low-income communities in the context of 400 years of structural inequality and the stabilization of poverty. I think young people represent a sort of important conversation for us to have as a culture. So we're looking at reimagining mental health through the eyes of young people, sort of trying to get it out of the medical model, looking at race and class, trying to celebrate young people's wisdom.
And it's not isolated just to Northern California.
No.
No, okay.
We're looking at the state of California.
Excellent.
Literally, our 5-year initiative is focused on reimagining mental health as a support for healthy development, not as a response to pathology.
And what an important time to be looking at this in the midst of everything that we've all been through, especially young people in the last year. Yeah. Wow. Well, you have the perfect background for what I want to do today. I have entered this like imbroglio myself with some flawed assumptions. So I'm owning the fact that as a layperson, I have had my eyes open to some things about the county and how it serves as a conduit for funding that I never understood before. So I want to give you an example. I did a little exercise. I contacted someone who was running for mayor of Los Angeles, someone who was running for city council, and someone running for a state assembly seat. And I asked them this question: what percentage of the LA County Department of Mental Health budget, what percentage of that budget do you think is funded by the county general fund? And the answers that came back to me ranged between 20 and 50%, which is kind of where I would have been also. You and I know it's more like around 2 or 3. So unpack for us a little bit. My first assumption is that local taxpayer dollars pay very little into county mental health budgets. So if you can describe in layman's terms, without a PowerPoint, because we can't do this here, people are listening, what are the various sources of funding that pay for mental health services in our local government here?
Yeah. Well, I will answer that question directly, but to begin with, Californians say that access to mental health is the most important issue in the public sector to them for now 3 straight surveys by the California Healthcare Foundation. So it's a great question you're asking. Like, does our budgeting match our priorities? And the fundamental answer is no. And to understand that, you have to look at the construct of county health systems in the context of the broader county bureaucracy. So one way to look at your county is there is a public safety side. That's the sheriff and the DA. And there's a health and human service side. That's the health director and the welfare director, or social service agency director. And while the budgets look sometimes proportionate, your point is extremely well taken that actually the vast majority of the dollars counties get to decide about go to the sheriff and the district attorney. And the sheriff and the district attorney are elected, whereas the health director and the welfare director are appointed. So you can hear where I'm headed going, right?
Exactly.
Like it's a structural issue.
And a political issue.
If only there was some old white guy smoking a cigar in the back room and we could take him out. Like, that would be great. We'd have done it, right? It's not going to work that way. It's actually the system is working as it is designed to work, which is it privileges the carceral side and underprivileges the treatment and social justice side. So your point is extremely well taken. You asked, how is the mental health specifically funded, DMH? And to understand how DMH is funded, we call them the big 3. Los Angeles Department of Mental Health gets 3 primary sources of funding from the state. Those 3 are the Mental Health Services Act, Prop 63, 1991 realignment, and 2011 realignment. But the way to think of that is millionaire's tax, vehicle license fees, and sales tax.
So we have to unpack that word realignment because, it sounds like we're going into the auto mechanic.
Yeah. So let's take a step back. The counties get money from the state in a bunch of different ways. And then they sometimes get local money. And then they spend it. And they try to get a federal match on it per minute, per patient, per type of service. And counties vary dramatically in their ability and sophistication in securing those matching dollars. But the simple way to think of it is the state gives in different buckets money to the county spends it, and then retroactively tries to claim a federal match on that expenditure.
So we need to intercept this with a discussion of Medicaid for a moment, because you can't get the Medicaid dollar without having the local match. Okay.
I mean, the way to think of Medicaid, known as Medi-Cal in California, is it's a pot of gold sitting in D.C. You get $1 if you put up $1, very roughly. So the state gives the county some dollars, and then the counties try to pull down the federal match. Not very successfully. And then the counties and the state point their fingers at each other about who's at fault for how much we suck. So back to your first question. The counties have an extraordinarily large administrative burden that in most states, the state holds. But in California, the counties hold.
Well, I want to underscore that. Presumably, prior to this first realignment that you mentioned, which was 1991, I think you said, the state would disperse money to the counties. They decided they wanted to get out of that business, basically.
Well, let's even go one step further just to try to describe to your listeners what realignment is. And we're getting into the weeds. So
it's okay. My people can take it.
So basically, this realignment is California's name for what you and I might call a block grant. So we often talk about fragmentation, right? Like child welfare and juvenile justice and healthcare and education. I might call that horizontal fragmentation. Mm-hmm. To understand the dysfunction of California's safety net, you have to look at what I might call vertical fragmentation between the feds, the state, the counties, and the providers. And it's just really, really challenging in that situation. So that issue of how counties receive their money has been problematic since the early 80s when we created this system. So basically, to understand it, California calls, when one level of government is freaked out about its financial exposure, what it often does is bundle some programs together and shove it down to the next level. Reagan called it devolution. You and I might call it a block grant. Mm-hmm. California calls it realignment.
Okay.
And so no small irony that California's progressive politics say, don't block grant Medicaid, all the stuff about feds, don't block grant. while at the same time, it's turning around and block granting to its counties. So basically the state of California has twice, in 1991 and 2011, faced massive budget problems. And what it did is said to the counties, hey, I'll give you flexible dollars if you take my responsibility. And the counties sold their soul for those agreements by saying, yes, we'll take flexibility in the context of privileging the sheriff and the DA in exchange for flexibility.
So ergo, we have 58 different ways to address mental health.
Correct.
Okay, so we will come back to that one in a moment. We've got the basic premise set, and I appreciate that. And I love the way you're drawing those word pictures. So this makes it all more challenging since we can't have a PowerPoint here. So observation number 2, I spent a lot of time in the homeless arena, as I know you do as well. And I've come to realize housing first, which is the preferred federal policy, which basically suggests that people should go directly from the street to a home without the intermediating need to go into a shelter or some kind of sobriety, service or whatever. Street to home, hand them the key. That's the preferred policy position of the federal government and what I would also call the homeless industrial establishment, those who are involved with building permanent supportive housing and servicing it. I would argue that housing first sidesteps the real needs of people with serious mental illness. And these are the people that we see walking barefoot down the middle of the street. In my observation, these are people who would not immediately survive if handed a key to an apartment. So my question would be, do you think we are missing an important piece of this housing puzzle by focusing solely on housing first as it relates to people with serious mental illness?
Yes. Housing first is a just and equitable narrative and strategy. So would we but have a system where everyone could be handed a key and given the support necessary to succeed in that setting? That is not what we have. And in fact, I concur that housing first has in some ways been used to disinvest in other services that are necessary and appropriate in any reasonable continuum. So it's difficult. Systems of oppression thrive when people who should be aligned are pitted against each other. So what's happened with housing first is because it's a just and right narrative, it's right action. Of course, everyone should be given the most permanent, stable housing possible as soon as possible. But in the context of an under-resourced safety net, what it's led to is disinvestment in shelter, disinvestment in treatment beds under the rubric or the ruse of housing first, and just practically it doesn't work. We need to have a more nuanced conversation. Of course, there is no magic wand. We're fighting the impact of 400 years of structural inequality. It's not like one thing that's going to fix it.
And it's not going to be fixed overnight.
Well, you might need to say in the context of a massive federal disinvestment from McKinney-Vento in housing starts. Like the failure of congregate housing programs, the HUD housing high-rises, the failure of those systems led to a disinvestment that was not replicated or reproduced in community-based settings. And so what we have now is a dramatic federal disinvestment and basically an ethos or an argument that's replaced it without access to those specific resources you named. Front-end treatment beds. Shelter is part of a continuum. Mm-hmm. Obviously, you don't want to spin people into shelter and then back out every morning. That's not what we want to do. But you do need a place to receive people to help them prepare for the next step.
Right. Yeah, absolutely. All right, we're going to come back to the treatment beds in a moment. We're continuing along this path. Observation number 3, which I think you started to touch upon, there are no agreed upon outcomes for our mental health system in California, or systems actually, if we talk about the 58 counties, despite what I saw in the 1991 original realignment block grant policy articulated that there should be outcomes. How can we go now for 30 odd years? You can be super busy, but if you don't know what you're trying to achieve, what's the point?
Well, when you construct policy on fiscal drivers or on a protectionist fiscal narrative that says, I am doing these things so I can protect my budget, state or county. So state to protect its exposure, county to protect its investment in the carceral system, then you get a fundamentally under-resourced system. So like whatever else people say, like I hear people say all the time, oh, we're spending enough money. That is just not true. Like any reasonable comparison about what we spend per beneficiary would show you that we are not, by any standard measure, investing enough. Now, it's not just about money either, of course, right? Of course it's not. But the fundamental reality of John Sharon's job at LADMH is he is under-resourced. And he's making impossible decisions in the face of massive human suffering. So he cannot solve the problem that he has been given with the resources at his disposal and the administrative tools that he must live under. So those reforms must be done.
So back to those outcomes, what would be an example of an outcome or two that seems we could agree on, but we're all afraid to articulate? What would be an outcome or two?
Well, there are some really standard ones, like
Okay.
just super simple. Like things like network adequacy and timeliness to care. These are standard measures in the healthcare system. Like, are there enough treating professionals that when you need access to care, you can get it in a reasonable time? We have measures in California that are fake. Like they exist, but they're fake. Like they're not resembling any reasonable or appropriate understanding of if someone is in real need of a mental health service or support, can they get access to it? No. Is someone in real need of a place to sleep, can they get access to it? No. So we have done no proportional assessment of the number of homeless people and the availability of resources commensurate to that number, despite all of our actions, despite all of our things. Like we have sort of a serial entrepreneurialist approach in California where we elected comes out with a plan. They say, this is going to solve it. It has big, huge numbers attached to it, but it isn't tied to any reasonable or data-driven approach to need.
Yeah, and I think to that point, the electorate is seeing that right now. They don't know quite how to put their finger on it, but they're seeing that something is not working here, right?
Yeah.
And those outcomes right now would have to be state-driven. You can't have 58 counties coming up with their own outcomes.
My narrative was largely around resources. So an outcome would be that anyone who needs a shelter bed can get it. An outcome would be that anyone who needs access to mental health services can receive it within 18 to 24 hours. An outcome could be that anyone who is discharged from the hospital is discharged into a treatment setting necessary and appropriate to their need. We could go on.
Yeah.
Those are super simple ones.
Right.
And anyone who suggests we have those now is never actually worked in the safety net.
All we have to do is look on the street to say that we don't have outcomes. So kind of continuing on this outcome discussion, observation number 4 would be what I'm observing, and based on what I've heard from people who work in the system, that mental health outcomes, or what might be defined as success, are more tied to successful reimbursement outcomes rather than patient recovery or wellness. What does that mean?
Well, it's a function of like the need is so overwhelming and the resources so insufficient that you are, and I can say this from having led a system, that you are literally hustling all the time to get another street health outreach worker out there, to create another treatment bed. And so your success is measured by how much human suffering you can mitigate. It's not a strategy for success. It's a strategy to, save your soul. Like I'm, thinking about it now, I'm realizing like how many people were discharged from our psych emergency into nothing. Like,
we see people wandering with their hospital bracelets still on, right?
Yeah. Like I'm super empathetic, and this is certainly no critique of John or anybody who works. Like I have the deepest respect for public service, but no, you are managing to a budget, and for the most effective and successful leaders, to incremental improvement in access to care in an overwhelming sea of need.
So, and the way it's been described to me, Alex, is that, and I think I've seen, you may have said this or someone else, that people who work in the system, they're taking care of the charts. They're documenting everything that they're having to do down to 15-minute increments. If they screw up or mess up or they don't provide the right service or the right documentation, the county can be dinged. Then the match money you're talking about will not be provided. And so there's almost like a sense of anxiety. It's been described to me also that this whole process of documentation is soul-sucking for someone who actually entered this work to help people. Can you give some examples of that?
Yeah, totally. I mean, and I've filled out these forms as a clinician in public schools, in the emergency department, in community-based settings, in foster care and juvenile justice, in homeless encampments. 30 to 40% of your time is literally spent completing forms. Most opening episodes in the 2 primary Medicaid reimbursement streams are between 18 and 40 pages long. An opening episode, right? Just to start. And they are all diagnosis driven, meaning to qualify for reimbursement, you must take the experience of someone's presentation and put it into DSM-5 categories. Now, for a lot of the adult, seriously mentally ill folks, that's unnecessary and appropriate. I mean, treatment works. There are mentally ill people. For a lot of kids, that's not appropriate.
You're labeling them right off the bat.
And it's also pathologizing kind of the impacts of, a culture that equates fame with merit and wealth with value and is built on 400 years of structural inequality. So we don't do that in our systems. We don't name those things. We're starting to. Our amazing Surgeon General, Nadine Burke-Harris, is starting to bring forward a narrative about what happens to you, your social and emotional welfare, and your physical outcomes when you are exposed to certain things in childhood. And I think that's an important conversation to help reframe the medical model. You can't do this work. And I know this may be hard for listeners to hear when they see a floridly psychotic man, right? And they wanted to get him on meds. Meds are important and treatment is essential. But all of that has to be held in the context of a culture, our culture. And a data point I like to show is there's this really weird data point called daily adjusted life years. It's weird. It's a combination of days on disability and days spent in the hospital by a diagnostic criteria. In America, behavioral health is far and away the leading cost driver for health systems. We spend more on behavioral health than any other disease burden, but it's unique to America. Other industrialized nations spend nowhere near as much as we do and have nowhere near the same impact because of the way they treat the mentally ill in their communities.
Right.
Less stigma, more integration, more community engagement. And we have to actually accept that we as a culture are making people sick. It's not just pathology. It's some pathology tied to a culture that has not negotiated an appropriate social contract.
Yeah, I mean, this is what I observed in Trieste. That was so powerful. And I really, when I was there for a month embedded in their system, I saw it in action. They do not see people as a diagnosis. When someone encounters their community mental health center, they call it a center, not a clinic, there's nothing clinical about the experience at all. And they try to grasp that person's life story, everything from, did you play the flute in 5th grade? And who's your family? And, what sports team do you like? But more importantly, they then focus on their life aspirations. What do you want to do with your life? Do you want to go back to school? Do you want to travel? Do you want to get a job? And their role is to connect the dots between the life story and the life aspiration. And it's so non-clinical. And in the time that I was there, they never talked about people in terms of their diagnosis. It was just I
think that's so right. I have literally billed, I don't know, hundreds of millions, maybe $1 billion of Medicaid mental health services. Every single child and family I served had to have a diagnosis. And for about 10 or 15%, maybe even 20% of the families I served and the children I served, that was appropriate, actually. Like, I believe in narrative therapy. I believe in meds. Like, I've seen people's lives transformed. But for 80% of the young people I served, they were dealing with a really bad thing that happened in their life.
Some trauma, yeah.
Usually, and living in a culture that told them they weren't worth nothing. Your story about Trieste, I think that's exactly right. We have to change the experience of people of our system and have it far more focused on human connection and relationship and empathy and compassion.
So when you say that putting up that initial file could be, did you say 18 to 20 pages?
18 to 48 pages is an opening episode for both short doyle and EPSTT, specialty mental health services.
What are they worried about? That we're somehow going to be treating someone that doesn't need the help?
Right. Well, and that's part of the dysfunction between the state and the county and the provider, right? In scarcity, we fall back into authority and rigidity. And so that leads us to try to think, they're getting, like, I can't tell you how many systems I have where the county thinks the providers are getting over them and the state thinks the county's getting over them. The feds think the state is the culture of interaction is broken. Yes, a different kind of reimbursement system, what we might call payment reform in the Medi-Cal space, is gaining steam as an essential change. But it has to be done in the context of anti-racism and social justice and that compassionate entrance that you named in Trieste. Like, it can't just be payment reform. Yes, there's too much burden. Yes, this is a dumb way to do it. But if you just change the money without changing the ethos, you won't get what you need.
You won't go where you want to be. Okay. We will come to payment reform in a moment. Observation number 5, you kind of touched upon this, but I want to circle back. It would surprise me to learn that in California, there was no state department of mental health per se. Some states have it, we don't. The counties, as you have described, are left with considerable discretion, and services vary from county to county. I was talking to one friend who's a service provider of adult residential facilities in Northern California, and she says that her company has 22 different county contracts and 22 different sets of outcomes for her particular endeavor. So should we rethink this? Should we scoop it all back up and try to centralize some authority? Has the Pandora left I don't know, was Pandora in a bag or a box? I can't remember.
Yeah.
The cat was in the bag, Pandora was in the box.
Mm-hmm.
Is this working?
No. And unpacking 40 years of bad policy will take some time. So to be fair, there's no easy outs, but it is changing. In the larger jurisdictions, Los Angeles County is bigger than most states. Even the county that I led, Alameda County, was 1.5, 2 million or so bigger than a handful of states. So for the larger counties, to me, it's not as much a question of should we have fewer of them, as it is unpacking the bad policy decisions that have kind of privileged local control, which, if I hear another state leader say local control is basically code for I don't have responsibility anymore, so I do think there's a way to re-engineer that relationship with common expectations and clearer boundaries. Now, the way the state has done it is increasingly shifted responsibility away from county mental health plans to managed care organizations. So this is a really important thing for folks listening to understand. We are in the age of ascendancy of managed care in Medi-Cal. So Medi-Cal being the California version of Medicaid.
Mm-hmm.
Historically, if you had a mental health issue, you could only get care, if you were poor, from your county mental health plan. That changed in 2015. The state shifted a set of benefits into the managed care organizations. So in LA, that would be LA Care and Centene. And basically now if you're in Medi-Cal, instead of having a card that says Medi-Cal and you're in a fee-for-service program, you're now in a health plan like you and me.
So everybody would be.
About 90% of 80 to 90% of everyone in Medicaid, of the 12 million people in Medicaid, are enrolled in managed care organizations. And it's really important for folks from the outside to understand that increasingly managed care organizations, the health plans, are being looked to by the state as the healer of this broken safety net.
Right. Interesting.
Now, it's true, because I've been interviewing all the CEOs for a project for the Robert Wood Johnson Foundation. You probably couldn't have picked a less likely savior of poor people. But on the other hand, I also understand why the state's doing it, because the counties have become unregulatable in the context of constitutional protections, Prop 30. I could go into the details, but the autonomy of counties is so strong, and the political history between counties and states is so rife with tension and drama that the state, under the leadership of Dr. Galley and Will Lightbourne, is increasingly pushing stuff into the managed care plans. And it's going to be messy. It's going to be ugly, but I understand why they're doing it.
Okay. So that's something to watch and to kind of cheer for, in a sense.
I think everyone has to have eyes wide open, because it matters less who the payer is, than what happens for poor people. So I think we all need to embrace change, but then have an eyebrow raised.
So what would be an example of something that you've seen start to be handled differently or more expeditiously under the managed care context than before?
Yeah. Well, so most of them are just coming now. Something called enhanced case management, or in lieu of services. So for the last 5 years, counties have been doing this thing called whole person care. It was basically a chunk of money that came in from the feds to go after homelessness. It had limited outcomes. It was meant to prime the pump for something bigger in managed care. Mm-hmm. That's starting to happen now. So now what's going to happen is the health plans, not DMH, is going to start to write contracts to community-based providers to do things like discharge planning from psych emergency, to do things like care coordination in shelters, to do things like provide services to those scattered site Section 8 vouchers that people are getting. So in theory, you'll see more LA Care, Centene paying for stuff that historically DMH has paid for.
And the service providers, are they necessarily health providers, or are they also like traditional service providers that we might see in the homeless services space?
Well, that's the most important question. If you want to critique this change, you would say, wow, health plans, they pay for hospitals and ambulances, not for caseworkers, not for peers, not for beds. And so it's a stretch, but it's also a new revenue stream because DMH isn't going away. Mm-hmm. But DMH has struggled to expand to meet the need. So from my perspective, I'll take any new resource. The need is so massive and overwhelming that we should invite anyone who wants to do stuff for poor people is welcome. Bring it. And the managed care plans are the deepest pocket.
And so, therefore, Department of Health Services, Dr. Galley and his team, this is where some of the coordination and more centralization can rest.
They're going to try.
Okay.
And I think there's a lot of critiques, but I would like to say that I deeply respect what Secretary Galley is trying to do, which is unpack a lot of bad decisions relatively quickly through a relatively ambitious reform agenda.
Another good reason we can't recall our governor.
It's funny you say that. Whatever you may think of Governor Newsom, we have the most extraordinary man right now in leadership of our Health and Human Service place. Secretary Galley is truly an extraordinary man. We must all invest in this guy because, he's not going to get it all right, but he's thinking about it right.
And so we just gave him a shout out in this podcast. All right. Observation number 6. This is one that I've had a hard time wrapping my mind around. We have a documented shortage of psychiatric treatment beds across the entire continuum, from the time you enter the ER to, that would even include board and care homes. There's a famous statistic, I know you're aware, the Treatment Advocacy Center has recommended a minimum of 50 public mental health beds per 100,000 population. LA County has 22, and the state of California has 17 beds per 100,000. So there apparently is no viable way to finance the beds that we need. And when we talk about homelessness and the need for housing and the need for beds, we are not factoring in these beds into that kind of whole continuum of care. So talk a little bit about why this is so complicated to come up with the very treatment beds that we obviously need.
Yeah. What's essential to understand the needs of the homeless in a continuum, homeless advocates call it the housing ladder. And an essential component of that ladder is beds for the seriously mentally ill so that they can be stabilized and get what they need. The essential thing to understand about the beddedness conversation in the ladder, so understanding how many beds you need at each level, is those numbers have to be seen in the context of movement. They only work if people are moving through the system. Because if you make a bed and don't provide an out, that bed is dead as soon as someone gets in it. Yeah. So that what historically happens in these conversations is, well, I need X number of beds. Yes, you do. So we're underbedded. Come on now. We can have a nuanced conversation. Yes, we need more. But until those beds are articulated into a system of care where movement happens, the term permanent to supportive housing should be thrown in the garbage. There's nothing permanent about supportive housing. Anyone who says that is imprisoning poor people in their dysfunction. People get better. Treatment works. And you should be able to graduate out of supportive housing into Section 8, frankly, into self-sufficiency. Mm-hmm. But we don't engineer that. The conversation gets static. This goes back to that serial entrepreneurialism thing I tell you about. Everyone is so stressed out. The human suffering is so hard to hold in our hearts that we cathect. We grab hold of one solution and say, if we only just did this, it's not that. Take a step back out, let your gaze soften, look at the entire ladder, and name the numbers and name the articulation of levels of care to each other and the expected movement. That's what the solution is.
That's so interesting. It would require inverting our system to actually focus on the person at each step of the ladder. Okay, you have now... I was actually in a board and care home just a couple days ago visiting a few people, and there were a few women living in this facility. It is a facility. I hate to call it that. Let's call it a community. I think they could live in their own apartments, but there's no one who's going to help them navigate out of that place into another spot. And there's no attached social worker or case manager to do that. So those precious beds are kind of locked down.
Well, when we talk beddedness too, I want to talk about the bottom of the ladder, which is even people with serious mental illness can live really successfully in community-based settings with appropriate support. And so we've learned these amazing lessons, call them what you will, full service partnerships. For kids, we call it RAP. The field calls it assertive community action teams. You can very successfully support even the most seriously mentally ill people in non-clinical or non-facility-like settings with appropriate team-based care.
Mm-hmm.
Knock on their door every 4 hours. Hey, buddy, how
check
you
on
doing?
them. Yeah.
You know, human connection, right? It's like, and what we've done though is we pioneered these sort of community action teams in the mid-90s. They proved incredibly successful in depopulating Napa State Hospital. And then we stopped. Like the system that I led, we had 3,000 treatment slots. Now we needed about 20,000, but we proved those 3,000 worked. And we didn't ever grow them to scale.
Because how would those have been paid for?
Exactly.
That was the problem. So you would have had to negotiate with the sheriff's department to see if you could...
We would have needed more local resources, more state funding, and easier access to the federal match. So it's both bottom up and top down to provide the non-federal share and a more streamlined and effective way to claim the federal match.
Is there any county in California who has actually been able to tap into more of their local resources to expand that kind of service?
There are isolated examples of extraordinary resilience and creativity. One of the reasons I don't jump to answer your question is by highlighting them, we create a false narrative that they can be done at scale, and they can't.
They're usually smaller counties.
Yeah. Or even in bigger counties. In Alameda County, we were basically 5% of the Medi-Cal population, but we claimed about half of the administrative dollars across the state. So oftentimes people say, well, how come all the other counties? Now, I've been going out talking to these other counties, and the answer is it's really hard.
Yeah, the documentation burden is huge.
You got to count for every minute. You got to have a time tracker system. You got to fight the state off. The state's got to fight the feds off. You have to, it's a mess. And so my belief is that rather than highlight these extraordinary examples of people working in a broken system, let's acknowledge the fact the system doesn't work. Redesign it. And engineer it for success.
So one more question on that bed shortage issue. I keep hearing, it doesn't happen every day, but over the past couple of years that different hospitals have shut down their psychiatric wards. The number of private mental health beds have also shrunk. Why is that?
I'm not sure I can answer that fully because I'm not present in those discussions in private health systems. So I do not know what the drivers are. My instinct tells me that these are questions of stigma and structural racism.
I just don't want those people here at our hospital, maybe.
Having run one of the busiest 911 systems in the state, I can tell you the number one call I got from private hospitals was get the psychotic folks out of my emergency department. Over and over and over. That was the number one priority. They didn't want their elective surgery people running into them in the parking lot. It was just, the primary thing they were interested in changing.
Interesting. Okay, we'll put a pin on that one. So observation number 8. I've heard this from people, and so I just want you to help us understand this. If you are experiencing both a mental health crisis and a substance use addiction, which we see a lot of that on our streets, it is impossible or maybe extremely difficult to receive treatment under the same roof from the same provider, which from the outside looking in seems to make absolutely no sense. What is that all about?
Yeah, it's a legacy of fragmentation that we attempted to address and didn't get there. Los Angeles is, frankly, way behind the times on this. In the mid-90s, there's something called Medi-Cal consolidation. The state tried to merge its drug and alcohol, AOD system, alcohol and other drugs, and its mental health system into these things called behavioral health departments. And it was a administrative integration, but not really a payment or service level administration. So in most counties, including mine, we had a whole separate world who administered the AOD services. And the mental health staff sort of called themselves sort of purists. I'd have therapists come to me and say all the time, well, I don't do drug and alcohol treatment. Well, 60 to 70% of the chronically homeless have a co-occurring disorder. So, and if you're treating teens and you're not talking about drugs and alcohol, you're not legit. So part of it is an old cultural stigma associated with drug and alcohol abuse, that those are the less worthy of the suffering people. And so there's actually a professional stigma. But there's also a cultural one, like you chose that problem.
Mm-hmm.
And so the combination of the cultural stigma and the professional stigma and the historical division between the two services. Believe it or not, Los Angeles still administers its drug and alcohol program separate from its mental health world. AOD is administered in the public health department, whereas John handles mental health services.
Right.
This is a preposterous structure. I mean, it's as bad as the other fragmentation issues is. LA is something that absolutely fundamentally needs to change. Those systems need to be integrated, and there should no longer be any bright line in treatment between drug and alcohol abuse and behavioral health disorders.
So somebody who is listening to this interview who might be thinking of running for county supervisor, is this the kind of integration that needs to happen at the county level?
Absolutely. I don't know the politics, so Barbara and John, I hope I'm not throwing any things out there that are going to get you in trouble, but I think as bad as the integration worked out in the mid-90s, it was an improvement, and LA should take that on.
Well, I think it's a question that, people in the community ask, like, why can't this person, see one professional to try to address all these issues? Yeah. So,
well, it's one important point, I think, for listeners to maybe hold. Like water and power and waste management, Health and Human Services is becoming increasingly a publicly procured, not a publicly provided system. So go with me for a second.
From private.
Well,
okay.
Think about it for a second, right? Like historically, a county staff member would treat you or do outreach. But increasingly, that function is being contracted out to community-based providers for a number of reasons. First, they're cheaper. No pension obligation. Second, it's easier to manage. Civil service sucks.
Yeah.
It's super supportive of labor organizers and all the work they do.
It's more malleable.
It's way harder to hire someone and then fire them if they're not performing than it is to administer and manage a contract. Third, you're more likely to find culturally competent staff in community-based settings than you are in civil service. So I'll stop. There's probably other reasons, but those are the financial drivers. But this shift from publicly provided to publicly procured means that there's a kind of growing provider class that is interacting with our public systems. So think about it for a second. Like the biggest providers of Medicaid are actually Kaiser and Sutter and Dignity, not the public hospitals, not DMH. So you have to think of the counties a little bit differently than we used to. Even they're evolving from doers to buyers. Now, LA still has a pretty significant county direct service, so it's not entirely clear. In the kids' world, it's vast majority providers. Hathaway Sycamore.
So that brings more voices into the mix, and maybe more progressive and kind of reimagining voices.
I was trained by people who taught me this space that seek influence, not control. Like purchase, don't provide. That it's a more effective way to do safety net services. And I'm sure there are probably labor organizers and others who are super freaked out by that comment. But I found as a leader of a system, it was easier to, I got better service, was able to change more quickly, more live, more flexible, more responsive, more culturally relevant when I purchased than when I hired.
Thinking about that distinction is kind of mind-blowing for me. That actually gives me some hope. All right, number 9. We've started down this road, and this is super complicated, I know, but I want to go back to this payment reform concept that you mentioned. And I keep hearing, yes, this is also something to be hopeful about. It is a much touted way to create more flexibility in the Medicaid reimbursed mental health system. We hear about this thing called CalAIM, which is the California Advancing and Innovating Medi-Cal acronym, and which I personally find incredibly complicated to understand. I've heard of this thing that, okay, there's going to be this shift toward, and you've already mentioned it, enhanced case management and in lieu of services, but that none of this really is going to kick in for another couple of years. Like, what do we need to focus on in this discussion as lay people?
So let's go back.
Okay.
Remember how I said in the beginning, like that part of you that wants to understand but gets confronted by the complexity? Indulge it. Like,
thank you.
Yeah. So like, I appreciate the question, and I would definitely encourage everyone who's listening to this, like, it's not too complicated. You can get it.
Okay.
So basically, Medicaid in California has been bifurcated into the managed care plans and the county mental health departments.
Which you've already started to describe.
So think of that like MHPs, the county mental health plans, MCOs, the managed care plans. So in LA, that means LADMH is a mental health plan, or LA Care and Centene is a managed care organization. Basically, we are in the age of the ascendancy of the MCO. The managed care organization, LA Care and HealthNet, are being asked by contract to do more and more and more and more and more. And the mental health plans are largely staying stagnant because of some of the structural challenges they face. The administrative burden, their revenue model, their competition with public safety actors locally. So payment reform is an attempt to clarify the negotiation and relationship between the two and simplify MHPs, simplify John Sharon's job at LADMH, make it not as administratively burdensome to go get that federal match, not have to have hundreds of contract staff using Access and Excel spreadsheets
not do the 18 to 20 pages of reports.
Reduce documentation burden. Basically, create a coding system that's consistent between the MCOs and the MHPs. Right now, the MCOs use CPT codes. The MHPs do not.
What's a CPT code?
It's the traditional way we code a service for a reimbursement. And it's the way that doctors and hospitals all do it one way, but the mental health plans
Those are all the little numbers that we see when we go to the doctor?
H0643. Yeah, exactly. It's a type of thing. And so at a minimum, we should be measuring the same thing. We should be using the same definitions. We should clarify the responsibilities between the two. We should ease the administrative burden. We should go get that federal matching dollar. Like California has the 4th highest tax base in the nation. We get about the 35th most federal match. So we're not going after the money. No. I mean, everyone here who's a good business person should be like, yo, I'm paying these high taxes, but we aren't getting the commensurate federal match.
So by reducing some of these handcuffs, we possibly could go after more of the money.
Absolutely.
Okay.
I would say the primary focus of payment reform is administrative simplicity, both at the documentation and the claiming level, increased federal revenue, and alignment between systems.
Okay.
If we are successful at it, and again, I want to say to Will Lightbourne and Secretary Galley and all the people at the state who've taken this challenge on, we've had 20 years of no one taking this on. So as messy as it is, or if anybody wants some hope, there's some really good people who have stepped up to the plate with courage and intelligence to take this on. You know, it's not going to get fixed quick, but the conversations are happening. So yeah, I think there's some hope.
So how do lay people engage in that right now? Is there still time? Is it baked already?
No.
Or is it just a matter of...
Well, geez, to go into the details, there's these things called waivers that get renegotiated every 5 years. The state has submitted. They'll get approved in the next 30 to 60 days. They'll be implemented beginning January 1. So a new improved system with clearer relationships between the MHPs and the MCOs, in theory with reduced administrative burden, and in theory with more opportunity for federal matching funds, should begin as early as January 2022. Yeah,
okay.
And won't be fully flowered for 2 years after that.
Okay, that is encouraging. So finally, last observation, and you've done an amazing job of describing these things. I wish people could see your hand motions.
Whiteboard. We need a whiteboard.
Yeah, we need the whiteboard if we had a whiteboard. But I will, with your help, insert things into the episode notes of things that people should be reading. Yeah. So finally, and we did already kind of touch upon this, but I want to end here. Currently, our American mental health system is more accountable to the institutions that surround it and not to the people it's intended to serve. And an example, I was recently in a conversation about trying to even expand mental health services on a 24/7 basis so we can get the police out of the middle of the 911 call. And the conversation devolved to, well, the unions aren't going to like this, right? Well, who are the unions here to serve? The person has a crisis at 3:30 on a Saturday afternoon. Our systems are not there to serve them. So how do we shift from preserving the institution to changing that perspective to focus on the person?
Yeah, that really resonates with me. I mean, that's what, led me to have to take a break from the public sector, was exactly that question of, in therapy, we ask whose needs are being served. And I have spent far too much time serving the needs of bureaucracy. the only thing I can say to you in honest answer to that question is I do not know. So like you have to begin with, I think, that humility of like, these are entrenched problems that have been constructed over many years. But I think the answer is spend more money, specifically invest in agency and power of beneficiaries. And I'm going to define those terms.
Okay.
Agency defined as who does the work. Power as defined by who gets paid. So we think, many of us who are working on these issues, that beneficiaries have to be directly organized and engaged in the systems that serve them. And that means redefining who does the work and who gets paid to do it. So taking power and agency from the existing systems, be they the mental health plan or the health plans or the clinicians, and shifting it to people who are not as immersed and embedded in the medical model. So I think the greatest hope for reform in California's safety net systems are the recently announced provider class expansions.
So describe that a little bit more.
So just coming, beginning in January.
What we've just been talking about. Yeah. Okay.
The state has announced that they are going to add community health outreach workers, doulas, behavioral health coaches in schools, and peer-to-peer certified treatment staff to the Medicaid scope of benefits.
Which is huge. Huge change.
Yeah. So I know it might be really hard for people listening who see floridly psychotic people on the street to hear someone on a radio show say something like, it's not about doctors' beds and ambulances and hospitals. It's not about doctors, ambulance beds, and hospitals. It's about love, compassion, and human connection. And that the more you make that clinical, the more impossible the task becomes by cost, by workforce, by administrative burden. And if we reimagine our safety net systems in ways that more directly engage people with lived experience, peers, doulas, CHWs, coaches, we can develop a lower cost system that's more responsive and more effective. So I think actually the key is to break the medical model.
And so what you've painted for us today about the shift to private providers being able now to play a greater role in the system. I think you talked about their ascension and just their ability to kind of be more flexible, malleable. Likely these changes are going to be connected to the private or nonprofit sector and less to the county sectors.
Yeah. I mean, the way I manage that question publicly is let's not care as much about who does it and care more about what happens, but the what should be treatment teams that aren't necessarily all therapists or all social workers or all psychologists or all doctors. Like, why can't one social worker work with 5 peer health outreach workers who make a living wage, who look like the people we're trying to serve, who have relevant lived experience, who can build relationship? Because most homeless people need a relationship more than they need a therapist.
Yeah. One of the interviews this season was with a young man who served on the Cahoots team in Eugene, Oregon, which obviously is very much focused on people with lived experience. And you don't necessarily have to have an LCSW to be on the Cahoots team. And he said the best candidate would be someone who is like a bartender or a barista because they could just talk to people for as long as...
So true.
Yeah. And so shifting to who does this work is really fundamental.
And what if, to be hopeful for a second, what if we all looked in the mirror and said, can we build a social movement based on care and consideration for the most vulnerable people in our culture? And it doesn't have to be through beds and clinics and medication. Those have a place. So please, we don't have to throw that out. We can have a nuanced conversation. But the fundamental reform of the suffering we all see on the street is less about those things and more about looking in the mirror.
Yeah. I love the way you kind of wrap this all up in a bow. So let me ask you this. I'm going to, again, hypothetically say, I'm running for mayor of, name any city in California, San Jose, Los Angeles, San Diego. And I know that people are going to be pounding on my door about the visible crisis of untreated mental illness on the streets. And as a mayor, I don't have a lot of control per se. And I know I already emailed you, like, should cities, establish their own mental health departments? And you already disabused me of that notion. But armed with this knowledge, especially after this conversation, starting to do more kind of like research, what do you think a city mayor should do to bridge this gap between the need and the delivery of services in a way that's, not pejorative, but could be helpful.
Yeah. I would give some sort of a practical and then an advocacy position. The practical position is to partner with your county every time you spend $1, because then they can pull down a federal match on it. So just the incremental, open up your books, sit down in a humble, honest way with your finance team with you in a room with no windows and break down your budget and look for opportunity. And I'm weird. I'm a weirdo. I think that's really sexy, good work, important work. So that's a practical recommendation, is look at your expenditure pattern and hunt for opportunity to bring down federal matching funds specifically. On an advocacy level, we have to expose the primacy of the carceral system in county government. And I know many, many people who work in probation and the sheriff department, the DA, who are amazing people. It's not a personal attack on anybody. But we started today with your question about how much money do you think counties are spending of the dollars they control on the most important issue to California? And we know it's pennies on the dollar for what they're spending on the public safety side. And I think if I'm a mayor, I want to know why the county isn't spending more money of it, the dollars it controls. Remember, not every dollar is created equal.
Right.
You have to understand which dollar is which. How come the county isn't spending more of its locally controlled funds on this issue that is so essential to all of our health and well-being?
Sometimes just asking the question can start to break things open.
Yeah, and there's a natural, how I said there was a tension between the feds and the state and the counties and the counties and the providers. I could have thrown the cities in there. Cities have their hands tied in these long-term relationships with police and fire. So they have their own kind of burden. But I think that there's a specific step to be taken, which is if you're spending a money city on something that's eligible for a match, but you can't get the match, partner with the people who can.
Yeah.
And then second, respectfully, collegially, pull the curtain back.
Look at what's going on behind the Oz curtain. Yeah. I learned so much just from this conversation. The last question I will ask you is, what is your hope quotient for the future? I know that the system can just burn people out. And I know you left the county after so many years. That's a tough job. I don't envy anyone running a county health or mental health system. It's enormously difficult. But do you feel like there is a movement, there's shifting? Do you feel hope for the future? And how would you define that?
I mean, I'm generally a hopeful person. I think we made these problems, we can unmake them. So I believe we are living in a sort of a socially constructed epidemic of despair, and we need to respond. My hopefulness comes in for a specific reason, which is the recently announced reform agenda at the state level. Again, it's going to be messy. It's not going to happen overnight, but I believe in the leadership at the state, and I believe in the ambitious agenda they've laid out. So I think reform is coming. So that's a hopeful thing that I have. I also think there is the emerging of a conversation around race and class that is different. It's hard. White people have a lot of trouble holding it. It's difficult to have it in a way that people can put down their burdens. But any of us who've spent our lives working in low-income communities know that that's what's going on. Ask any emergency room social worker, what's bringing people into the front door? It's not pathology. It's poverty, it's race, it's housing, it's social determinants. So I think what gives me hope is the emerging understanding by every doctor I know who wants to work in policy, including my wife. Everybody who's working in these safety net systems realize they're insufficient. And so I think that there's an emerging understanding that healthcare systems have to address race and class. That makes me hopeful.
That's awesome. Well, I so appreciate you taking the time today, Alex, and unpacking this. And you did a stellar job of just wading through. I don't even think you used any multi-syllabic words and not too many acronyms. So I wish you a safe flight back home today to Northern California, and I look forward to seeing you again soon.
Yeah, thank you for having me.
All right. This conversation with Alex has caused me to think about the strategies we can employ to stay focused upon the people we are trying to serve, notwithstanding the preservation instincts of the institutions that create barriers to placing people first. Put a different way, how can we press to simplify a system that is so complicated that it arguably harms the very people it is intended to heal? But I think we must link arms with impatient, creative thinkers who have insights into this space and insist that our city and county leaders work collaboratively to optimize funding to meet the visible needs that we cannot ignore. We must join with those willing to take advantage of some of the positive trends highlighted by Alex toward the end of the interview. The increasing role of the managed care organizations, the inclusion of more nonprofit providers in the service array, and the emergence of young leaders with a fresh perspective and an aversion to maintaining the status quo. This episode brings to a close Season 2 of Heartforward Conversations from the Heart. With Labor Day looming, this is a good time to take a break and focus on some of the other initiatives we have in the works in Los Angeles. Our Radical Hospitality Initiative and the planning that is underway to stand up a mental health clubhouse in Hollywood in 2022. Here's hoping that when we start up again in the winter, this current COVID surge will be in the rearview mirror. As a timestamp, we are holding our collective breaths as the Delta variant has its way right now and is particularly dangerous for those who are not vaccinated. The country's death rate due to COVID now stands at 635,000 departed souls. And schools are attempting to safely reopen so our children are not relegated to more time isolated at home. Thank you to all of you who have listened to the first 2 seasons of this podcast and have helped to spread the word. We passed a milestone of 5,000 downloads just a few weeks ago, and I love hearing feedback from listeners who are having their eyes opened to things that they really had never considered before, and they find reasons to hope for the future. As always, thank you to my collaborating partner, Peer Mental Health, and Paul Robinson, who provides technical support to bring this podcast to the platform. Thank you especially to all the financial supporters, because this is entirely self-funded and self-produced. So your support makes all the difference. See you in 2022.